Hello and welcome back. We are talking about lower limb tendons in today's lecture/ presentation. So to start with, we need to talk about anatomy. So we've got lots of tendons in the body. Just get my laser pointer up. So we've got lots of tendons in the body, and we seem to have positional tendons such as your lateral hip tendon, your elbow tendon, your tibialis anterior tendon as well. And these tendons seem to have a different structure to what we call the energy storage and release tendons. And the most famous energy storage tendon, and probably the most structurally different tendon, energy storage tendon, is the Achilles tendon. So the structure seems to be different, and therefore the function seems to be different. So with the Achilles, we're looking to store energy and then release energy to move the bone or the joint. And we're not really so sure yet if the anatomy or the classification of positional versus energy storage has implications for rehab just yet. The main focus for today's presentation will be on the Achilles and its energy storage and release functions for rehabilitation. So here we have some rather gruesome images of some Achilles tendons. So the Achilles tendon is a very large tendon. It's actually three tendons coming together. So the soleus tendon, the medial and lateral gastrocnemius tendons all come together and twist at about the mid portion medially, and then insert down here on the calcaneus. And so the function of the energy storage and release tendon is to store elastic potential energy and then release it to cause movement. Okay, so if I have an elastic band, for example, I'm going to stretch the elastic band, and I'm storing this as potential energy, and then when I go to release, now there's kinetic energy, and therefore the elastic band goes flying, or I propel myself forward down the tarmac. So what I'm doing here is I'm transferring force from the muscle, contracting and stretching or tensioning the tendon, storing the energy to the bone, and therefore the joint's going to move. And then tendons are our way of being efficient. So tendons save us energy. Tendons don't require oxidation or have much metabolic demand, right? So whereas a muscle requires oxygenation to keep contracting for over periods longer than a minute, let's go and say. So basically, if I'm running 1 kilometer and my muscles are constantly contracting and they constantly require oxygen, I'm going to then fatigue, and then my heart's going to start beating faster, and my respiratory rate is going to increase, so I'm going to breathe slightly harder. If I'm able to store more energy in the Achilles tendon per step, and then therefore release that energy to propel me forward, then I'm therefore not going to require as much muscle metabolic activity, and therefore I'm going to become a more efficient runner by storing and releasing more energy through the Achilles tendon. So therefore, ideally, to cope with loading demands, we would prefer a stiffer tendon to a more compliant tendon, as we're then going to have to do more work at the muscle. And then just in terms of the structure or the properties of the tendon. Tendons are harder than muscle, they're softer than bone, they're less stretchy than muscle, more stretchy than bone. They're more brittle than muscle, less brittle than bone, and then they repair more slowly than both muscle and bone when they're injured. So we are thinking in terms of remodeling and cellular turnover in a tendon. We're thinking more so weeks to months rather than a matter of days to weeks. Let's go and say if you tear a muscle, you grade 1, you're looking at probably weeks, days to weeks for that to sort itself out. Dead giveaway there is the color of the thing. This thing is red, so it's got a pretty good blood supply. The tendon is mainly collagen and has relatively poorer blood supply than the muscle. It's going to take a lot longer to remodel and turn over because we're basing that off mechanical load or mechanotransduction. So tendons exhibit these viscoelastic properties. And so what that means is they exhibit non-Newtonian behavior. Another thing that exhibits non-Newtonian behavior is something called Oobleck fluid. I'm sure you guys through science at school may have played around with some Oobleck fluid before, but what it's like is, and this is an image here of someone punching the fluid, but what it means and what this viscoelasticity word or term means is that if I am to load the fluid with a high rate, so with speed, so if I go and punch the fluid, then the fluid is not going to deform. It's going to behave extremely stiff or non-compliant, and it's going to be like me hitting a concrete wall. Versus if I submerge my hand or fist into that fluid very slowly, so a low rate of loading, then I'm easily going to be able to submerge my hand and it's going to be immersed into the fluid. And so tendons exhibit this same phenomenon. When a tendon is stretched quickly, so therefore a high rate of loading, they are very stiff or they behave very stiff. And then when tendons are stretched slowly, there is a low rate of loading, they're going to behave a hell of a lot more compliant. Okay, so a couple images here. I've got Usain Bolt running down the track. If you imagine his Achilles tendon as his foot strikes the ground, his foot's only going to be on the ground for, let's go and say, 100, 200 milliseconds. And therefore, the rate of loading is extremely high. What that's going to do is it's going to mean he can, his Achilles tendon is going to behave extremely stiff. It's going to store and it's going to release a ton of energy. It's going to be very elastic. And then versus a snail, for example, this thing's obviously going to be moving very, very slowly and it's going to be a lot more compliant. And then you need to go and ask, so why is this the case with tendons? And the answer is in the structure of the tendon. So we've got this thing called the IFM, or the interfascicular matrix of a tendon. So if you take the whole tendon here, or the whole tendon in my little infographic diagram here, you're going to have these steel cables, which are the collagen fascicles, right? And they've got a very small amount of stretch. Okay, so that's how you can imagine the collagen. It's like a steel cable. And then you've got, surrounding the steel cables, you've got this proteoglycan-rich jelly type of substance, which is called your interfascicular matrix. The interfascicular matrix gel also has these proteins such as elastin and lubricin, which allows the tendon fascicles, as you can see over here on the right hand side, allows these tendon fascicles to slide over the top of each other and move force around or attenuate force as well. And so that allows the whole tendon to have almost double the tensile strength as a singular fascicle, right? Because we've got this sliding and attenuation of force and moving force around, which helps the tendon become exposed to much larger forces without deforming or rupturing. So the IFM also houses your tendon cells or tenocytes, and then also nerves and blood vessels. As you can see down here in the bottom image, we've got these from Jill Cook and Hazel Screen. We've got this little diagram here demonstrating the cellular makeup or the busy environment of the IFM. And then this full picture is taken from Jake Tura, and he is an absolute wealth of knowledge for lower limb tendons, mainly patella and Achilles. So would definitely recommend checking him out and all the work that he produces. Okay, yep. So collagen sliding, which is we think the lubricant, and then shearing and attenuating or moving force around, as we said, and then that stretch and recoil is mainly contributed to by the elastic nature of the tendon, or the viscoelastic nature of the tendon, which is present due to elastin in the tendon. And then when it comes to a tendinopathic or diseased tendon, the IFM we think is involved as well, or at least Jill Cook and Hazel Screen hypothesized this as well. And basically what they hypothesized was that the IFM, or the intervesicular matrix, may be the site of this reactive or first stage tendinopathy. So let's go and say let's use the sprinter Usain Bolt for another example, and he has done a block of training, and then he starts pulling up, or maybe it's a lead up to a competition where he's training a little bit more, and he pulls up a little bit sore through his Achilles tendon. He may simply just need to stop for a couple of days or a week, maybe 72 hours to a week, and then jump back into his training, and he would be completely fine. Okay, so there's this idea that we have a normal tendon, we load it excessively, and then it falls into this reactive tendinopathy, which may occur in the interfascicular matrix, and therefore that be the driver of nociception, versus if you continue to load on that reactive tendinopathy, we may start to go into a state of tendon disrepair, and then degenerative tendinopathy, where we start to see disorganized collagen, or that really cooked spaghetti type of arrangement of the collagen fibers. So the collagen fibers become messy, basically. And there is also this theory when it comes to this reactive tendinopathy and the pain that it produces. There's this theory that the reactive nature of pain is simply the body's way of saying you're at your adaptive ceiling, right? So Usain Bolt's gone and done his training, and because he is training at very high volumes or very high frequencies or very high intensities, his Achilles is now screaming out to him, going, hold on, mate. If you keep loading at this volume, intensity, or frequency, then something is going to go wrong, right? You may start to then develop some problems with the collagen in your body. And so without any large structural change to the collagen, the reactive tendinopathy may just be telling us, hold on, we cannot adapt any further to the stimulus. You need to back it off completely. So in summary there, we have, one sec. In summary there, we have our energy storage tendons and our positional tendons, and primarily we're looking at energy storage and energy return, and then more so control and just the transfer of force from the muscle to the bone to move a joint. We have strain capacity is very high and strain capacity is much lower. We'll talk about strain in a moment. We have IFM elasticity, which is high, and IFM elasticity, which is low, so lower content of elastin and lubricin here, much simpler intervesicular matrix. We have lower IFM stiffness, so the actual gel itself is quite compliant, allows that attenuation or the sliding of the fascicles, tendon fascicles over the top of each other. And then we have, it's much more stiff in these positional tendons. And then, as we spoke about, there's these proteins and specialized proteoglycans in the IFM, and there's less of that in the positional tendon. Your tendon fascicles, or as we say, steel cables, very stiff, and likewise in both tendons. So here we're looking at the difference between these two is actually the IFM. And then we have, when we get a little bit older, we get a bit more stiffness through the IFM and therefore less sliding, less elasticity as well. So could be contributing to why the tendon does get stiffer, but also less able to deal with high amounts of force as we age. Alrighty, and as I just said, we are now going to start to talk about tendon strain. So tendon strain is the percentage of length change given the normal resting length of the tendon, right? So the example is, if I have a 10 centimeter Achilles tendon, so let's imagine we've got 10 centimeters worth of Achilles, and then I go and pull that Achilles from either end, and it stretches 5 millimeters, right? Then we have 0.05 over 1, which means it is changed 5% in length, right? So we're gonna say that the tendon has strained 5%. Same story, you can do this with an elastic band as well. Resting length and then stretch length. Okay, what's the difference between the two in terms of a percentage? And that's going to be your tendon strain. What it seems like is, it seems like we need to strain a tendon to cause a tendon stiffness adaptation. And if you remember, we want a stiffer tendon than a more compliant tendon, okay, because it will allow us to store and therefore release more energy. But it seems like, and this has been determined from a lot of groups around the world, but mainly the German or Berlin group, the Aaron Patzis, Volk Mersman, Sebastian Bohm group, they seem to think that in a healthy tendon, we need 4.5 to 6.5% strain for optimal tendon stiffness adaptations. So if we're underneath 4.5 to 6.5% strain, so let's go and jump over to this figure here. If we're under 4.5 or 4% strain, it seems like there is no, or there is a very minimal tendon stiffness adaptation. But then we go out to the other end, right? And if we're sitting over 8% strain, it looks like the strain is too high, and then we get a poor remodeling or a poor tendon stiffness adaptation. So we start, rather than the tendon kicking out collagen 1, which is primary collagen, it's going to start to remodel with collagen 3, which is much more like your scar type of collagen, so it's poor quality. And then it seems like the sweet spot or 4.5 to 6.5% strain is akin to 70 to 100% of maximum voluntary contraction or 1 RM. So these loads have to be very heavy, it seems, to achieve your 4.5 to 6.5% strain. However, every tendon is a little bit different, okay? And this figure demonstrates this very well. So this is from Gerard McMahon's paper, No Strain, No Gain. And what it's telling us is that if we pick someone off the street and they have a relatively stiff tendon, it is going to require 70 to 100% of their MVC to get this 4.5 to 6.5% strain and therefore see a tendon adaptation. Versus if we go and pick someone else off the street and they have more of a compliant tendon. Okay, so can you think of what population this may be? Maybe we're dealing here with an athletic population. Up here, maybe we're dealing with a little bit more of a sedentary population. So if we pick this person up from the street and then we load them at 50% MVC or all the way up to 80% MVC, that's going to be their optimum zone for tendon stiffness adaptation. And if we go higher than that, 80 to 100%, then we may be overdoing it for this person, right? So here comes the person-centered or this individualized nature of tendon rehab. And interestingly enough, when a tendon becomes tendinopathic as well, it seems to fit into this more higher tendon compliance category. So when we have a tendinopathic tendon, maybe we don't actually need these super duper high loads to create enough strain on the tendon for tendon stiffness adaptations. But it does depend. And look, this may as well reconcile some of the work that's been done showing no difference between groups in terms of tendon pain as well with high load or moderate load. And that I think is because pain is a little bit more messy than just tendon strain. But in those groups, we still saw tendon stiffness adaptations when loads were a little bit higher. And then lastly, we can measure this using our dynamometry. So we can measure this using a force plate and then therefore use these theoretical models to load our patients in accordance to their outputs in terms of their triceps surae force production or their plantar flexion abilities, basically. So we're thinking that tendon strain matters for adaptation or tendon stiffness adaptation. But the other thing about tendon strain is also applied to the tendon across a certain amount of time. Right. So we've got force and we've got time. So not only does tendon strain matter, but tendon strain duration also matters. Because in fast movements, so let's go and take this high jumper here, as they plant their foot on the ground, their foot's only going to be on the ground for, again, less than 200 milliseconds. So strain is going to be quite high on the tendon, maybe around 10%. But the tendon's going to behave very stiff, right? And so the tendon is going to store a lot of energy and release a lot of energy in a very short amount of time. And a tendon doesn't want to be stretched necessarily, so it's going to recoil. However, in a slow movement, so let's go and take this Smith machine deficit calf raise. In a slow movement, there is going to be enough time for, as I was speaking about before, for this sliding or attenuation of the collagen fascicles, right? So the collagen is going to slide and it's going to rotate, it's going to reorganize, we're going to break cross links to then for them to then bond again. And the cells or tenocytes mainly in the IFM are then going to be able to sense this load or this loading, and it's going to alert them to therefore create an adaptation for the future. It's going to go, hold on, we didn't like that amount of loading. We couldn't necessarily tolerate that amount of loading. So we're going to change something here and we're going to kick out more collagen, or we're going to make more crosslinks, and therefore we're going to be able to tolerate higher strains in the future or more force. This window seems to be about 3 to 30 seconds. So anything under 3 seconds, we don't seem to think that there is enough time for this reorganization to happen. But anything over 3 seconds, we do believe that this can happen. So as I said, tendon strain becomes important, but tendon strain duration is also very important for long-term tendon stiffness adaptations. And then this could also be why plyometrics aren't consistently shown to create these tendon stiffness adaptations, even though strain is high versus heavy slow resistance or eccentrics are consistently shown to increase tendon stiffness and create tendon stiffness adaptations. And overall, we want a stiffer tendon because it can tolerate more force. That is going to provide us performance benefits in terms of reactivity or athleticism. We can go and then test the MVIC of the plantar flexors by setting it up on a force plate, and then we can use this for testing and training purposes because it allows us to identify where we may be or where we may be sitting regarding those theoretical models of tendon strain based on that figure I demonstrated before. So we can see if we play here that we have a perpendicular setup ratcheted down. We've got a starting load, and then we're now contracting, and now we are producing outputs of 140 kilogram of force. And then what I can do is I can take 50%, I can take 70, I can take 80, I can take 90% of that MVIC, and then prescribe based on that number. This is a good image here of that testing setup. Okay, there is arguments about the degrees of dorsiflexion that you need to be in. Anywhere upwards of 10 degrees of dorsiflexion is going to allow your soleus to be in that more optimal length tension relationship, and therefore we're going to get more of a look at your true peak or true MVIC for the plantar flex or for the soleus basically. And then, as I just mentioned, pain then is a little bit more messy than tendon strain and tendon biomechanics, we think. So there's a nice little infographic here from, again, Jake Tura, and what this demonstrates or it summarizes is this paper here from the Scandinavian guys. And what it looked at is pain improving and then the structure of the tendon staying very similar after 12 months of patella and Achilles tendinopathy. So we can function well, we can perform, and we can also have less pain. However, we can still have a poor or altered tendon structure. Okay, this is probably because pain is a little bit more complicated than tendon structure alone, as we can see over here, and then we can see down here the multifactorial nature of pain. And because of this, I like to think about tendon pain as a low grade, almost smoldering pain response or smoldering inflammation. So we're not thinking of our typical inflammation. We're not thinking of, say, you sprain your ankle and there is redness, hotness, fluid, pain that comes along with it. We're more so thinking of this low grade inflammatory response. And we kind of think this because there are immune cells present and there are also inflammatory cytokines and inflammatory mediators present in tendinopathy. There also seems to be an absence of our pro-resolving mediators, as in pro-resolving from an inflammatory standpoint. And so then we can almost take a guess and go and say that maybe the tendon or the body is trying to resolve and turn itself over and heal itself, but it does fail. Okay, and that's sort of much like that cycle that we see in osteoarthritis as well. So basically, what we're thinking is probably more so to do with the system, that human system, or the neuroimmune processes in that body, or the metabolic processes in that body. And looking at the problem like this from a pain standpoint certainly helps reconcile why all these biomechanical and structural variables seem to stay the same, but pain tends to improve or worsen, or there's flare-ups. There's this day-to-day sort of fluctuation when it comes to tendon pain. The other points that are interesting is that there seems to be these peripheral mechanisms at play driving nociception, so nociceptive pain. And then this nice paper by Ebony Rio as well, and our fellow Aussie colleagues, describes some central nervous system contributions and also potentially even some neurogenic inflammation associated with tendon pain as well. So in summary, tendon pain is probably more so a system-wide problem rather than simply a tendon problem itself. And there's also growing evidence that medical history factors such as type 2 diabetes does influence the metabolic profile, systemic profile, and therefore risk of tendon pain as well. So what do we do for tendon pain? Well, it's my belief, and I think the evidence is going to be pointing in this direction as well, but it's my belief that we prioritize load tolerance and other controllables that we think have associations to pain. So in terms of pain management, we need to consider our biological factors that are shown to be associated with or have a correlation to pain. Load management. So if you have someone that seems to demonstrate symptoms closely related to loading, such as they're an athlete, they run, they get tendon pain, they don't do so much running, they don't get as much tendon pain. Then load management education is essential. And load management education refers to the envelope of function for that human system. And so if they spend too much time up here, then they're at more risk of developing tendon pain for this population. And so we know that modification is greater than removal. We still want to apply some loading onto that tendon because we know that tendons do respond to load, and we don't want the tendon and the human system to decondition, the muscles around and the bones around to decondition if we completely remove loading around the affected area. And then on that same deconditioning point, just load everything else. So we've got a sore Achilles. That means we can load the quadriceps, we can load the hamstrings, we can load the hips, we can load the trunk, we can load everything else as much as we want to, basically, because there is a system around this tendon, not because it's going to necessarily do anything to the Achilles tendon or to that individual's mechanics, biomechanics at all. And then we need to look at some of the more system-wide controllables. We can look at sleep, we can look at lifestyle stresses, we can look at beliefs, pain self-efficacy, so confidence around pain, or especially around the activities that do seem to correlate with the person's pain, and loading can be one of them. Diet, smoking, drinking, again, other metabolic factors. Obesity, again, metabolic factors. Exercise and physical activity. And then the last point I want to touch on here as well is that when it comes to tendon pain, historically, there's been some evidence to show that loading is the way to go for pain relief. I'm of the opinion that in terms of pain relief, anything can work, and then also anything may not work as well. So there's not much consistency with loading and analgesic effects. It can go both ways. Some people there are, and then some people you may actually find yourself flaring up as well. And then just to point on Scott Dye's envelope of function here again, we may have different people presenting with tendinopathy, and we are talking about Achilles tendinopathy here today mainly. So you may have a sedentary population versus an active population presenting with tendinopathy. And then when it comes to loading and load management education, you may need to consider their envelope of function on an individual level as well. So if you bring us down here, for this active person, a jump from a 2-meter height or running for 1 hour sits within their envelope of function. This doesn't flare this person up at all. It doesn't worsen. They can manage and tolerate this level of loading. However, you then go and get them jumping from 3 meters. Then you go and get them running up hills for 30 minutes or running for an hour and a half, and this exceeds their envelope of function or their tolerance to loading, and therefore pushes them over the edge and may flare them up. Versus your more sedentary person, where they may be able to go for a 5-minute walk, and that may be manageable. However, a 10-minute walk or this jump or running for an hour may be well beyond their tissue or system capacity, and therefore they may flare up due to that relative overload. So considering the individual and what they've done in the past, what they currently do, past and then current function, that will give you some clues into how much you may or may not want to load this person with respect to risk of pain in that population. And then alongside loading or isometrics for analgesia, these are the adjuncts or passive therapies, and you may have seen therapeutic ultrasound, you may have seen some form of manual therapies, and you may have seen the use of shockwave therapy in the tendinopathic world or literature, but the evidence doesn't seem to support the use of these modalities at all, and the benefits of these modalities don't seem to outperform the contextual effects, or for want of a better word, placebo effects of using these therapies for pain relief. And so the use of these modalities is, I certainly wouldn't say never indicated, but it would require some very, very sound clinical reasoning for me to be supportive of the use of some of these therapies. And a good example is, just so you sort of can align with what I'm thinking, is that if you've tried let's go and say you've got someone with Achilles tendinopathy and you've tried a 6-month-long loading program, and there just doesn't seem to be any improvement. Alongside all of those so these previous points that we talked about, sleep, stress, lifestyle factors, exercise, physical activity, generally cardiometabolic health, weight management, all of these sorts of things, if they still were not improving, then and only then may I support the use of something like a shockwave therapy as almost a circuit breaker for this person. It may be the context that they need to as I said, create a circuit breaking effect, and therefore put them on the right path to recovery. And so now we get to talking about retraining tendons and retraining the stretch shortening cycle as well. And we don't have any formulas for tendon rehabilitation at all. And I do urge you not to subscribe to any formulas for the points that we just spoke about. This needs to be individualized completely and led by the person and their context and their goals and yada, yada, yada. However, if you are new to tendon rehabilitation, this can be an extremely useful piece of work from Professor Peter Malliaris of tendinopathy rehab. And so this is probably as close as you'll get to some type of formula for tendon rehabilitation. And what it is it's basically a tendon strain progression guide. Okay, so as we just spoke about before, we need to strain a tendon, and ideally between 4.5 and 6.5%, to create this tendon stiffness adaptation from a structural standpoint, an architectural standpoint. And what it is starting with your level 1. Okay, so your low tendon strain exercises, which then are a lower risk of provocation for tendons that are more load intolerant, all the way down to level 3 down here, which are exercises of high tendon strain, and therefore with a tendinopathic and load intolerant tendon, they do pose a high risk of provocation. And you would only do them or introduce them, the athlete, to these if you believe that they do require this type of tissue preparation or system preparation versus a more sedentary population. Maybe we don't need this level of tendon loading unless, of course, they want to. And so you would only sort of progress into these level 3 loading exercises when you yourself and your client or patient are confident about an improvement in their envelope of function or system capacity or tissue capacity. And then I'm a firm believer that once, and I think Karen Silbernagel as well believes that once symptoms have resolved, tendon loading should be part of the program for months, or I heard her talk about 12 months, so a year post resolution of symptoms, to reduce recurrent injury risk and then also maintain a level of integrity of tissue structure and therefore influencing performance. Okay, so what does this look like basically? We've got isometrics, and this is the holding, so HIMA, yielding isometric action in the inner range. We've then got holding in mid to outer range, and then we've got overcoming in mid to outer range at a submaximal level. We've got isotonic, so if you think flexion extension or plantar flexion, dorsiflexion, for a tempo of 3 seconds, 1 second, and then 3 seconds. So 3 seconds on the concentric, 1 second at the top, 3 seconds on the eccentric. And I'll show you what these look like now. Okay, so let's run through some examples of the loading progressions as per that Peter Malliaris document. So here we have an isometric hold. We in that sort of inner range. So for me, I'm up there at end of range plantar flexion, and then I'm holding that weight, and you can hold that weight for anywhere between 10 all the way up to 60 seconds, and we're getting four different contexts. So if I'm holding that for roughly 10 seconds, I'm more so looking at a metabolic fatigue of the muscle, and if I'm then going and decreasing that weight to hold it for 60 seconds, maybe all I'm doing is just exposing this tendon to some form of load with very low tendon strain and therefore low risk of provocation. Okay, so that's that early level one. From there, I'm working into my mid to outer range. So mid range, more plantar and then outer range is that more dorsiflexed position. And again, more tendon strain with further, as I move further into outer range, provided load stays the same. Okay. Then what I've got is some overcoming. I'm doing this on a calf raise machine. However, you can just load up a Smith machine with enough so that you can't move the load. And then we're looking at that mid-range, plantar grade, overcoming isometric. Okay, so we're looking at a sub-maximal effort. So I'm not putting out as much as I can, but we're sort of introducing this idea of a more of a high tendon loading rate or low strain duration idea. And I'm dealing with some classic heavy slow resistance here. So I'm moving at a 3-1-3 tempo isotonically. From there, we're dealing with this idea of, again, a little bit more intent on the concentric portion. Again, heavy slow resistance and a bit more explosive or rate of force development, quality development from the faster concentric action. From there, now I'm in outer range and doing a maximal pushing or overcoming isometric. And then looking at trying to find an extremely heavy load, doing slow eccentric. So as you can see, I've got some super duper high strain going through that Achilles now, and also a 6-second negative, so a substantial strain duration, right? Then we're moving on to our, again, more maximal isotonic movements. And then lastly, we have our pushing isometrics. However, we have an internally or externally rotated foot here to bias either the medial or lateral gastrocnemius head as well. And the reason we do this is because the Achilles tendon isn't just one tendon. The Achilles tendon is actually made up of 3 separate subtendons. Okay, so 3 tendons. We've got the medial gastroc tendon, we've got the soleus tendon, and then lateral gastroc tendon. They come down and then they twist at the mid portion of the Achilles, anywhere between 60 and about 90 degrees of twist or rotation, and then it goes on to insert down at the calcaneus. Okay, so we need to make sure that we are loading each portion of tendon adequately as well, so that each portion of tendon has load preparation or is able to withstand stress as well. And then lastly, we're going to bring in, well, we should sort of be dripping in some stretch shortening cycle work, but we're going to more so look at some plyometric activity to prepare that tendon, or I guess to bridge the gap between the heavy slow resistance and the sport that they want to get back to, which is going to require high loading rates of the Achilles or the tendon of interest, and then lower strain durations as well. So we're talking more now the plyometric strain duration, which is less than, let's go and say, 250 milliseconds of ground contact time. And so there is a bit of a nuance to plyometric training. My bias is that if plyometric training is done for long enough, and I think a lot of these studies have been done around about a 12-week mark, and there may not be enough time to create these long-term tendon adaptations, but we don't seem to consistently see in the literature that plyometrics yield the same tendon stiffness adaptation as the heavy slow resistance or isometric work at all. And so when we're doing plyometrics, we're probably working more so on system preparedness to tolerate loading rather than tendon stiffness, so to speak. And what this group out of Japan did was they did depth jumps pre and post a 12-week period of plyometric training. And what they found was that after plyometric training, there was a larger ground reaction force. Okay, so when they hit the ground, there's a larger peak ground reaction force after training plyometrically with the depth jump. On the depth jump after training with plyometrics versus before there was a smaller ground reaction force. Okay. Before plyometric training, they also found that there was a large change in muscle fascicle length, right? And so what this means is that there's a poor stretch shortening cycle contributed to by yielding at the muscle. So if my muscle is behaving eccentrically and concentrically, then it's not stiff enough for my tendon to become elastic or behave in an elastic manner. And so then after this plyometric training, what we saw was that we saw very marginal changes in muscle length. And so what that means is that now after plyometric training, the muscle, so the triceps or the calf muscle, let's go and say, is able to hold extremely strongly in a near isometric fashion. And that allows the tendon to do most of the work in terms of the stretch shortening cycle. So they can store a bunch of energy in that tendon, and then they can release it. They can behave like an elastic band. And that then was also shown in tendon length change as well. So the tendon was able to recoil more, okay, as we can see up here. And so therefore it must have stored and released more energy. What we also see is that of the medial gastroc on EMG, there was this myoelectric silence phase, and that is probably protective in nature. So as you're approaching the ground, the body doesn't really want to have to deal with these high forces, and so we think it may kind of switch things off a little bit, okay, as a way to protect the body from potential harmful outcomes. After the plyometric training, this little silent period wasn't noticed. Okay, so we're now able to, I guess, colloquially attack the ground, and the muscle can contract with a greater output. And so before, so the muscle didn't develop more power, right, due to the plyometric training, but the muscle was able to hold stronger isometrically rather than yielding as we spoke about here, and losing energy. And that means that a much greater force can be produced at the tendon, and the tendon can store and release more energy, which we spoke about on this spike just over here. Lastly, as I said, that central nervous inhibition, we think it's protective, and then there was no inhibition here after training. And so when we speak about plyos, we are probably talking about a reconditioning of and I like to say, you're going to hear muscle tendon unit, but I like to say neuro muscle tendon unit. Okay. So in summary, when we are talking about tendon rehabilitation, we are talking about preparing the tendon for loading, and whatever loading that may be in the individual's context. A great rule of thumb is to progress through from a low strain to a higher strain tendon program, which allows us to demonstrate changes in structure and architecture, which alters our tendon tissue capacity. Thank you.